What we did was we took two of our best databases and sets of estimates statistically. We took data from our cancer registry, the SEER program, and we also had information from the Census Bureau because they have made some very useful population projections that incorporate a lot of factors like longevity and births and so on. And so we put those two sources of information together to come up with an estimates of the breast cancer population and the incidence of breast cancer in the U.S. So what we did was we can estimate the rate of cancer from the cancer registry. We can multiply those by population estimates from the census and come up with an estimate of burden.
Okay, so what is the news then here in the United States?
Yeah, so, well, I think there's 2 points. So when we made our forecast for the total number of cases, not surprisingly, our forecast is it's going to increase, because we already knew it was going to increase. Our particular estimates, based on the most recent data, are for all breast cancers combined, including the in-situ cancers as well as the invasive, an increase from around 283,000 cases in 2011 up to around 440,000 cases in 2030. So that's about a 50% rise. So there's three factors driving the increase. The first is we have more people. More people are getting into the cancer-prone years. We have a big baby boomer cohort in this country, which is very large, and so there's just a lot of women who are getting into those years. The second is that life expectancy is improving. So many women are just living longer and living long enough to develop a breast cancer. And the third factor is the rates of breast cancer in the United States are very high, as they are in many developed countries. And not only are they high, but the incidence of the most common types of breast cancer, the estrogen receptor positive cancers, has actually been increasing slowly. So when you put all that together in the models, we come up with the estimate of about a 50% overall increase.
There were some interesting discontinuations in your graph. It seems that what women were doing in terms of hormone replacement therapy made a difference to the breast cancer incidence.
Yeah, well, that is data that were previously reported and widely discussed in the literature, and I pointed that out, the drop circa 2002. I wanted to point that out to just mention that our models can account for that sort of effect in order to get good estimates of the other parameters that we need to make our forecasts.
Why is estrogen receptor positive breast cancer on the increase?
Yeah, that's a great question. And I think the strength and the weakness of our study combined is, the strength is that we don't have to know the reasons why to make a forecast. So the forecast is useful for planning purposes, and we can make the forecast without knowing all the reasons. That's the strength. The weakness is, well, we don't have enough information to try to partition the increase into different sorts of risk factors. That would be a different type of study. Well, presumably the increases in ER positive and the decreases in ER negative are both reflecting all those factors, the lifestyle and so on. It's not clear at this time how to partition up and know exactly which causes contribute how much, but the specific information, I think, is useful in other ways, but that's not what our study was really designed to do. We were asking, how many cases are there going to be?
It is interesting that ER-negative tumours are on the decrease. What are the implications of that?
Well, I think the implication is that we don't really know all the reasons why, and so one of the points of a descriptive study such as ours is to highlight that it's happening, to raise awareness of that, so that investigators can go out and try to find those reasons. Now, one thing that is exciting, and the annual report to the nation highlighted this observation about that, about triple negative breast cancer, which is the most common type of ER negative. And they pointed out that parity without breastfeeding appears to be a very strong risk factor. So understanding the importance of this, but our study says it's important, it's a population trend. That's one association, really great to tease out all the different associations with other studies, because there may be some prevention clues that have been overlooked.
Now, you were also asked, and there was quite a lot of questions about carcinoma in situ, because you've categorized in situ cancer along with breast cancer. There were some worries about that, weren't there? Because we don't know the natural history of DCIS. What did you make of that?
Yeah, I think it's interesting. I hope our study points at the attention of understanding more about the natural history. So again, one of the strengths of modeling is we don't have to know the details of the natural history to make a forecast of cases. And I think from a purpose of population, these are events. Women have a diagnosis and so on, and they're reported as a cancer to the registry.
And very briefly, what do you think doctors, cancer doctors, should be doing about this at the moment?
Our data needs to get filtered through the experts who advise the cancer doctors, and that's what's exciting. We can provide information to help the people with those expertise make good decisions and focus on important questions. That's the purpose of a descriptive study, is to find clues.